the cornea. Objectives of the lecture: to know the main etiologies of the corneal transparency, to recognize certain common corneal diseases, and to know the impact of these diseases on the vision. The cornea is the anterior continuation of the sclera. It's a transparent structure. In spite of having a protective role, it's responsible for about 3/4 of the optical power of the eye. So it is the major contributor to the refractive power of the eye. Now let me mention the corneal layers. The cornea consists of 5 layers. From the outmost layer is the epithelium. The epithelium is a stratified squamous non-keratinized cells, about 5 layers that rest on the basement membrane. Inner to the epithelium is the Bowman layer. An important point: if the epithelium gets injury, it can regenerate within 48 to 72 hours. Next to the epithelium is the Bowman layer. The Bowman layer is a cellular superficial layer of the stroma that formed from collagen fiber. Now the stroma makes up 90% of the corneal thickness. It arranges irregular oriented layer. There is a special orientation of the collagen fibril in this layer, and the spacing between these fibril is maintained by proteoglycan ground substance. The maintenance of regular arrangement and spacing of collagen in this layer is critical for maintaining corneal transparency. An important point that the stroma, if get injured, if get damaged, it cannot regenerate. Then the desmet membrane, which is a fine lattice work, of collagen fiber, and this layer it has a regenerative potential. Then the innermost layer that is adjacent to aqueous humor is the endothelium. The endothelium is a monolayer of polygonal cell. This monolayer of polygonal cell is important also for maintaining corneal transparency and corneal detergencies throughout the life. Why? It can pump excess fluid out of the stroma. And if this endothelial layer get injury, corneal edema can develop. This slide shows causes of the corneal transparency. This device called specular microscopy. This is used to assess the corneal endothelial cell count. The important point here is the adult cell density. The normal adult cell density is about 2,500 cells per square millimeter. If the cell count reduces, for example, to 500, this corneal edema will develop and the transparency will reduce. There is normal loss of endothelial cell per year with age, but if it reduces to this level, 500, corneal edema will develop. We use this device to estimate the endothelial cell count before any intraocular surgery, before we proceed to intraocular surgery, to know if the corneal endothelium can tolerate this surgery or its hazard for the patient patient for developing for proceeding with the intraocular surgery, for example, cataract surgery. An important tool is to measure the endothelial cell count and to measure the hexagonal cell. Not only the total cell count, but we should know the hexagonal cell within the endothelium.
The cornea is a transparent structure. The causes of corneal transparency mentioned in the previous slide, and it's obvious, no need to be explained. What I want to explain here, the sign of corneal disease. Signs of corneal disease. The cornea has 5 layers. The signs of epithelial disease include punctate epithelial erosions. For example, punctate epithelial erosions. Look to the slide, the upper right side. The punctate epithelial erosion is a tiny epithelial defect that is stained well with the fluorescein. We have a stain called fluorescein. We use cobalt blue. There is orange strand. When you use the orange strand and you look through the cobalt blue, the area of epithelial defect will take a green color. This is punctate epithelial erosion, which is not a non-specific sign. You can see this punctate epithelial erosion in many conditions. For example, dry eye, reduced corneal sensation, poorly fitted contact lens. So it is a non-specific sign. What we have else in the lower picture, there is punctate epithelial keratitis. The difference between the erosions and the keratitis, there is no epithelial defect in punctate epithelial keratitis. It's just a swollen epithelial cell, not stained with fluorescein. It is stained with rose bengal, and can be. It is obvious. You can recognize even without a stain, like the lower right photo. Punctate epithelial keratitis may be the whole size of viral keratitis. You can see this punctate epithelial keratitis, for example, in adenoviral keratitis. A magnified photo. Here you can see the punctate epithelial erosions very clearly. It is stained with the fluorescein. So this is a fluorescein stained punctate epithelial erosion. In this slide we have punctate epithelial keratitis. There is no stain used here. It is obvious without any staining. Punctate epithelial keratitis, which is the hallmark of viral keratitis, for example, adenoviral keratitis. Another sign of corneal disease, this is filamentary keratitis. This is a mucous filament. Mucous filament can stain with rose bengal stain, not a fluorescein. This condition you can see in severe dry eye, for example, keratoconjunctivitis sicca. It's extremely painful condition. Corneal panel, a sub-epithelial ingrowth of fibrovascular tissue. It is stained from the limbus. It indicates inflammatory or degenerative condition. In this slide, there is loss of corneal transparency. This loss of corneal transparency, the cornea is hazy now. The etiology most likely to be post-surgical, because we see the stitches here, corneal stitches here. So this loss of corneal transparency may be iatrogenic due to the surgery. For example, after cataract extraction, there may be endothelial cell loss, excessive damage to endothelial cell, and there is corneal edema and loss of corneal transparency postoperatively. Another very important topic in our lecture is the microbial keratitis. Microbial keratitis could be viral, bacterial, fungal keratitis. What is the predisposing factor for microbial keratitis? Normal cornea can't get the infection. there should be a predisposing factor, and most likely there is disruption of corneal epithelium, the first barrier against penetration of microorganism. When it lost by many factors, it may lead to increase the chance for development of microbial keratitis, whatever the cause is. Let us look to the signs and symptoms of microbial keratitis. What is obvious in this slide, in these photos, for example, upper left, what we have, there is congestion, severe congestion, conjunctival and ciliary injection. What is the conjunctival and what is the ciliary injection? Usually in case of simple conjunctivitis, whether allergic or viral, bacterial, the maximum site for injection adjacent to the palpebral fornicial and palpebral conjunctiva. The fornicial and palpebral conjunctiva, while in certain conditions there is ciliary injection, which indicates the condition is more serious. The ciliary injection, there is juxtalimbal injection, okay, not only conjunctival, but there is juxtalimbal injection, and this condition called ciliary flush or circumcorneal injection, which may be the sign for keratitis, for uveitis, for angle closure glaucoma. So this ciliary injection indicates a serious condition. Return back to the upper left photo. There is ciliary injection. What else we have? Corneal infiltrate. Corneal infiltrate. This is the corneal abscess or corneal infiltrate, which indicates a focal inflammation. There is leukocyte, cellular debris accumulation in this area, and there is overlying area of epithelial defect. If you want to see the epithelial defect exactly, you should stain with the fluorescein. What we have else, we have pus in the anterior chamber, level pus. This is called hypopion. So if you have ciliary injection, corneal infiltrate or corneal abscess plus hypopion, it's so obvious that these signs of microbial keratitis. What does the patient complain? The patient complains from ocular pain, loss of vision, and red eye. So one of the cause of pain for red eye with vision loss is the microbial keratitis. What's our workup in this condition? In this condition, first of all, in this picture, aggressive condition, aggressive infiltrate hypopion, we should take a swab for culture and sensitivity. Then we start aggressive antibiotic, broad spectrum empirical antibiotic, working against gram-positive and gram-negative. Usually we use cephalosporin fortified. We use the vial and diluted cephalosporin with a diluted aminoglycoside to work against the gram-positive and gram-negative. In serious condition, advanced condition, I use vancomycin, diluted vancomycin. There is no vancomycin eye drop available. I use the vancomycin to prepare a drop. This is called fortified. So fortified cephalosporin or vancomycin with fortified aminoglycoside used in combination. This is for serious condition. For example, our photo here. Use hourly with mydriatics and cycloplegic. For ocular pain, we use cycloplegic to relax the ciliary body. It is the atropine here, the long standing, the atropine. We use also oral ciprofloxacin because of its good ocular penetration. For the patient follow-up is mandatory. The signs of improvement, you will see regression of the infiltrate. You will see decreased level of hypopyon, improvement of epithelial defect. Your patient comfort is very important. If the patient don't respond, your patient doesn't respond to your medication, so you have to contact the microbiologist to see the culture and sensitivity. If the patient have good response, even in spite of in such condition, for example, the culture and sensitivity not goes with your medication that you use, continue with your medication. If there is a good response. If there is no response, contact the microbiologist to choose the antibiotic that the infiltrate respond well. Another controversial agent used here is the steroid. The steroid used when the ulcer is sterile, when there is clear evidence of improvement, so we can use steroids. So please don't put the steroid as your first option. You should start antibiotic, mydriatics, encycloplegic. And if the infection involves the only eye, very aggressive infection, involves the only eye in patient with poor compliance, cannot administer topical medication, we can administer, the patient can be admitted to the hospital, but this is not for all cases. If there is a small eccentric infiltrate, also we can use single antibiotic, and we can and in this condition you cannot do the swab for culture and sensitivity. There is no need to do the swab for culture and sensitivity. For herpes simplex virus infection, there is a primary infection and secondary infection. We have history of skin vesicle, and there is a history of conjunctivitis, follicular conjunctivitis, red eye with lacrimation. In recurrent case, there is keratitis, and there is a diagnostic sign for viral keratitis. For viral keratitis, history of recurrent red eye with lacrimation, history of previous herpes simplex skin vesicle. There is red eye with lacrimation with the loss of vision. It may be not as severe as bacterial. The pain is not like the bacterial keratitis, because the viral keratitis cause corneal hypothesia, so the condition is less painful. The sign of viral keratitis, herpes simplex keratitis, this is a fluorescein stain dendritic ulcer. Fluorescein stain dendritic ulcer, the upper left photo, while the left photo rose bengal stain dendritic ulcer. If this patient with dendritic ulcer uses steroid for any cause, for example, he is wrongly prescribed for the patient, this will cause amoeboid ulcer, enlargement of the ulcer due to steroid. So steroid is absolutely contraindicated in viral keratitis or in any suspicion of viral herpes simplex keratitis. The treatment will be antiviral agent, for example, acyclovir 3% eye ointment 5 times per day for 2 weeks, and we can use cycloplegic agent, atropine, in such condition. And the steroid, as I mentioned, is absolutely contraindicated in this condition. Another important topic is keratoconus. In keratoconus, kerato means cornea, conus means the cornea assumes conical shape. In patients with keratoconus, there is corneal steepening. The cornea increase in corneal convexity. The cornea become more convex. The keratometry reading increase. It's not 43 diopters. For example, it is 46, 47, or may reach 60 in advanced case diopter. And there is corneal thinning. There is reduction in corneal thickness with apical protrusion of the cornea. The patient presents as a gradual loss of vision as any case of refractive error with a frequent change of spectacle. In the beginning maybe has regular astigmatism, but in advanced when the condition progresses, the astigmatism become irregular. The patient can't get 6/6 visual acuity with the spectacle. Another complaint of the patient with keratoconus may develop sudden loss of vision, and if he develops sudden loss of vision, this means the patient develop what is called acute hydrops, like in case which indicate there is distant membrane rupture, like in the lower right photo when there is central corneal opacity. What is the sign of the disease, whether in early stage or an advanced stage? We said there is corneal steepening, there is irregular astigmatism, so we should do refraction for the patient to know if he can reach 6/6 or not, 6/6 visual acuity. We can document our diagnosis by doing what is called corneal topography. Corneal topography, as shown in the left lower photo, this is a corneal map which will show us the corneal power. So if there is corneal steepening or increase in keratometry reading, we can notice this by the corneal topography. Also we can see the corneal thickness, detect the corneal thickness within the corneal topography. So we will see there is steepening of the cornea and there is thinning of the cornea. The obvious sign you can do in advanced case by ask the patient to look down, and you will see the eyelid how it become convex here. This is called Munson sign, as in the right lower photo. How we deal with the patient with keratoconus after we document that the patient have such condition. The condition is a progressive. As we say, this is a progressive condition. Your patient may reach advanced condition when there is extreme corneal thinning, when there is corneal opacity, when the only solution for the patient is keratoplasty, a replacement of the cornea. We don't want to for our patient to reach such condition. So any patient complains from frequent change of spectacle, change of the spectacle power. For example, I do the refraction for my patient, and after 6 months there is a jump in the power of spectacle more than 1 diopter. يعني احنا فحصناه وكان الفحص انه minus 2 myopia. For example, after 6 months it become minus 4. The cylinder, if it is increased more than 1 diopter within 6 months, also we should take this condition in our consideration, and we should do for the patient corneal topography to exclude keratoconus. Another important point is the family history. Those patients with conus have a family history of such condition. Also there is ocular and systemic condition related to keratoconus. Ocular condition, history of allergy, a history of a frequent eye wrapping, continuous eye wrapping. This is a predisposing factor for development of corneal ectasia or keratoconus. Keep in your mind, for a patient with keratoconus, LASIK refractive surgery is contraindicated. So if we want our patient to improve his vision, we will start with a spectacle in simple case and follow up. We can use rigid contact lens to reshape the cornea. with a plano power, 0 power, the contact lens. And nowadays we do collagen cross-linking, especially to stop the progression, because the condition is progressive during the in children is a progressive. Any child we do cross-link for him. For patient below 35, my rule is to cross-link all patient. The cornea for patient with keratoconus, their age below 35, because there is natural cross-linking of the cornea above 40. So for those at risk of progression, we do a cross-linking, collagen cross-linking. The cross-linking procedure include we use a photosensitizer, riboflavin, topical vitamin B2. Then we use UV light. With this riboflavin and UV light, there is a photochemical reaction that increase corneal rigidity. So we want to stop the progression and not to improve the visual acuity, or there is low chance to improve visual acuity with the cross-link. Another option is the implantation of intracorneal ring. The intracorneal ring will improve the irregular astigmatism, will reshape the cornea as well. There is improvement in visual acuity. There is low chance to stop the progression. Another option is the keratoplasty for advanced condition, when there is no rule to do cross-link, or to implant intracorneal ring for extreme corneal thinning, for advanced disease with high keratometry reading. Keratoplasty is another option. All methods for treatment of keratoconus in one slide. The spectacle, rigid contact lens for early case, the cross-linking done to stop the progression in a progressive disease, for example in children or those below 35 years old. The cross-link stabilize, prevent the progression but not improve, or very low chance for improvement of visual acuity. The ring improve the visual acuity, but there is low chance to stop a progression. So I can combine my treatment in patient with keratoconus, progressive keratoconus, by implant the ring to improve vision, and I do a cross-link to stop the progression. For patient with advanced disease, I can do keratoplasty like in the left lower photo in advanced disease. This slide show you the normal eye and keratoconus eye, how the cornea protruded more forward more, and this is called corneal steepening and protrusion in patient with keratoconus. The other photo, upper left photo, show central corneal opacity. Central corneal opacity can occur in many conditions, but here, if I gave you a history of keratoconus and the patient developed drop of vision, this indicates the acute eye drops and the break in descendant membrane, so he developed a sudden drop of vision. Otherwise, patient with keratoconus should develop a gradual progressive loss of vision, as any patient with refractive error with the frequent change of spectacle. The other photo show the intracorneal ring, lower photo, intracorneal ring that used for treatment of keratoconus, and the left lower photo shows the Munson sign. When we ask the patient to look down in advanced keratoconus, you will see the concavity of the lower eyelid.